This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker this evening, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, upcoming events, and then we'll introduce Dr. Tennant, our speaker for this evening, and have a Q&A session. So again, my name is John Furman. I'm manager of the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who's on the call, also leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 70 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback at these conferences that they provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you find over 250 products selected by EDSers for EDSers. The store is the only funding for this program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. So just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Upcoming events include our webinars, which are held twice a month on the first and third Tuesdays at 7:30 p.m. Eastern Time. Our next webinar is April 21st, and this is by Dr. Sue, who will discuss GI disorders in EDS. He is with the Medical College of Wisconsin. And this weekend, we will have a live half-day conference in Cincinnati on April 11th, and this is open and free to all patients and physicians. We will feature Dr. Midakaitis, Dr. Nielsen, and Dr. Ringer discussing Ehlers-Danlos and Chiari malformation. Just a reminder for our live attendees that the Q&A session will be held after the presentation. Feel free to submit your question at any time by clicking on the Q&A icon located at the top of your screen. After submitting your question, click the orange button, and your question will be added to the list for the doctor to answer verbally after the presentation. Our presenter tonight is Dr. Tennant. Dr. Tennant is going to talk about intractable pain in Ehlers-Danlos. He has been treating chronic pain patients since 1975, and he specializes in the research and treatment of intractable pain at the Veract Intractable Pain Clinic in California. He has authored over 300 scientific articles and books, including a handbook for pain patients. He is a member of the American Academy of Pain Medicine, the American Academy of Pain Management, and American Pain Society, and American Society of Addiction Medicine. He has formerly served as a medical officer in the U.S. Army and U.S. Public Health Service. He has also been a consultant to the U.S. Food and Drug Administration, National Institute on Drug Abuse, Drug Enforcement Administration, and several professional sports organizations. He is the editor emeritus of Practical Pain Management, which is the nation's most widely circulated pain journal for physicians. So just a few things that he's involved with. He can share more about his research and other involvement in chronic pain topics. And with that, I'm extremely excited to introduce Dr. Tennant. You'll see the slides are loading right now. I'm going to go ahead and turn over the microphone to you, Dr. Tennant.
Okay. Thank you very much. Can you hear me all right?
Yes, we can hear you fine. Thank
you. Very good. Let me say, first off, I am delighted to be with you. Number two, I started treating intractable pain. It wasn't called that at the time, but it amounted to the same thing. And I started back in 1975, starting a clinic as part of the Los Angeles County Health Department system. And I primarily at that time treated cancer patients and polio patients. And I never dawned on me, frankly, at that time that Ehlers-Danlos even was associated with pain. And I, like other physicians over the years, came to realize that I had patients in my clinic who had EDS and many times were undiagnosed. And at this point in time, I put EDS in the category of being in the top 3 or 4 most severe pain problems. A lot of people, for example, think that cancer pain is the worst of pain, but let me assure you that many EDS patients have pain far beyond any cancer patient I've ever seen. And so it's one of the pain problems that is severe. It's been very troublesome. Many physicians are afraid of the disease and of the kind of pain that EDS patients have. At any rate, I have come to, in some ways, I guess, subspecialize in treating the pain of EDS patients, and I do want to pass on to you what I have learned. Let me say right out front that this presentation is not designed so much for patients as it is for physicians. I say that because if you are an EDS patient and you have severe chronic pain, you will have to know more about what to do and what it's about than 99% of physicians. And so I'm going to cover the latest in science and the latest in clinical treatment. And I was asked particularly to talk about hormones, and that is because I've gotten known for my hormone work. I'm basically was an internal medicine and endocrinology specialist many years ago, and I've kind of carried that over. But I learned some years ago that you could not control intractable or severe pain without certain hormones, both for replacement as well as therapeutics. And I'm going to cover that. And I do believe that the EDS patients need to be very, very familiar with this. Now, the thing that I want to talk about first off is why EDS patients have such severe pain. And the second thing I want to cover is the new concept of centralization. Every EDS patient needs to understand this because it is the concept of centralization that is not well understood by the medical profession yet because it's fairly new relative to research, and those of us who are very involved, we're very familiar with it and comfortable with it, but it is a new subject, but one that I want you to know about. So I'm really going to teach you tonight what I know about it, and really almost as to what physicians must know, because a lot of you are going to have to go educate your physicians and other medical persons. You have a rare disease relative to a condition such as just simple lumbar sprain, for example, or arthritis, and so having a rare condition, you've got to do a lot of educating of your own physicians in order to get good help. At any rate, the first thing I want to talk about is from a pain perspective, why EDS patients have, a severe condition. So the real problem with, I'm just not quite sure how these slides are going because it's not going like I wanted it to there. Now I've got what I want here. The problem with EDS is that EDS patients can't turn off their body and can't turn off pain signals. And as you know, you can start literally in childhood having pain with EDS. And it is the constancy of the pain signals going from a damaged joint or damaged cartilage or damaged ligament that go to the central nervous system and end up resulting in what we call today centralized intractable pain. And the term centralized is a term meaning the process of pain doing what we see with phantom limb pain, and that is that the pain goes into the central nervous system, causes inflammation, and then embeds itself or implants itself permanently in the cells of the central nervous system. On this next slide shows you a schematic diagram of how this occurs, and this is almost universal among EDS patients. Now, it all starts out with a peripheral nerve injury. Centralization can also start with something like head trauma, for example, or stroke, or a disease such as encephalitis that gets into the central nervous system. But in most EDS cases, the initial pain is in the periphery, meaning it's outside the brain. It's in a hand, it's in a knee, it's in a hip, it's in a joint somewhere. Now, this signal, this pain signal from this injured area enters the spinal cord and the brain, and it causes something called microglial activation. Now, I suspect that knowing EDS patients as I've come to know them, most of you stay right up on things. You're trying to be as learned as you can. You're on the internet. You're reading. You're talking to other people. And so a lot of you I know the term glial cell or microglial cell. Now, microglial is the cell in the nervous system that is really a white blood cell. It is an inflammatory cell. It is the cell that is in the spinal cord and the brain that causes inflammation. And inflammation, we now know, is caused in the spinal cord and in the brain just like you can have inflammation in a joint. Put another way, most EDS patients are familiar with having inflammation in a joint as well as in their spinal cord and in their brain. But it is neuroinflammation as it is caused, which is the real problem. Now, with neuroinflammation, and all of you are familiar with what inflammation happens to be. All of you have had a boil. All of you have had a red joint. You're familiar with inflammation being hot and painful. And at any rate, in this process, you have a release of toxins. Now, these toxins will cause cells to start dying, tissue to start reforming, scars to form. And the real problem is that pain can get imprinted or implanted in the cells. And at this time, we do not have a cure for this condition. Now, a lot of people are making false claims that they may be able to cure pain that becomes centralized, but at this time, there's no hard scientific evidence for it. I know a lot of patients, including some EDS patients, that darn near have cured themselves. And one of my goals here tonight is to give everybody hope and bring you up to date on some of the work that I'm doing. And the work I'm doing is very helpful and hopeful, because I'm seeing people getting results, reducing their pain to levels that I've never hoped would be possible. I'm seeing people reduce their opioid levels down to rock bottom. In other words, I don't want to sound too missionary, but I'm extremely optimistic about the things that we're seeing today for EDS patients. Now, I want to talk about the criteria for the clinical diagnosis of centralized pain. This comes from an article that will be published in the next 2 weeks in Practical Pain Management. I just led a task force of physicians and with some nurse practitioners, podiatrists, and pharmacists to come up with a consensus, if you will, on how practitioners should diagnose centralized pain. And I would like to have every patient know this, because as you look at the next slides, I would ask all of you to ask yourselves, do I have centralized pain, or do I have just peripheral pain, or do I have some of both? But it's critical for you to know if your pain has centralized. If it has centralized, then you're going to need to go about dealing with your pain in a different way than if it simply is in the periphery. And by in the periphery, I mean you have some pain in your knees or your hips or your shoulders, for example, but it has not yet entered your spinal cord and brain and implanted itself in those organs. Here is the essential elements of centralized pain. Now, I would ask everyone watching this webinar to take a look at these 4 elements. If they apply to you, then you have centralized your pain. Number one, you've got to have a peripheral injury or disease, and EDS patients, by definition, have this because you have painful and inflamed joints. But the big one is constant pain. If your pain is there all the time, it never goes away, it's there 24/7, then you probably have centralized pain. If your pain is there only on some days or on some hours of the day, you do not have centralized pain. But the hallmark of centralized pain is pain that is there, that is constant. Now, we used to call this intractable pain, and we still do, but we really technically refer to it as centralized intractable pain. Now, the other thing one has with centralized pain is sleep interference. In other words, it's hard to get to sleep. You may get to sleep, but the pain wakes you up. The pain may be severe enough you can't get to sleep, but one way or another, it interferes with your sleep. And then number 4, you have fatigue. In other words, even though you got a good night's sleep and you have the right diet, the right attitude, you're still fatigued. And so those are the big 3, constant pain, sleep interference, and fatigue. Now, there are some other supporting symptoms that patients with centralized pain may have, and here is a list of those. And we're telling physicians that if you have 7 or more of these 15 symptoms, then that's very good supportive evidence that you have centralized pain. Now, I would ask everybody watching this to run down that list. And I'm aware that many of you, if not most of you, will have a great number of those symptoms. In other words, part of my goal here tonight is to let you know that you're looking at yourself in these slides and that you have company, and that a lot of these symptoms that you have are real. They don't mean you're crazy. They don't mean you're disturbed. This means that you have microglial inflammation inside your spinal cord and brain. And a lot of people, for example, will take a look at this and they realize sometimes that they have funny smells, or they can't remember anything, or they're depressed, or they just can't function some days. They spend most of their day in bed, for example. These are all signs and symptoms of centralized pain. Another thing that centralized pain does is activate 2 major physiologic systems inside the brain. One is the hormonal system, and the other is the autonomic sympathetic nervous system. And what that means, that is the stimulatory side of the nervous system, and its technical name is autonomic sympathetic, but you don't need to know that. But what we're talking about here is that these 9 physical signs may be a result of centralized pain. In other words, your centralized pain is like a battery sending out too much electricity. It causes your body to have hypertension, your heart rate to step up, you sweat all the time, your reflexes are too active, mydriasis is a dilated pupil, and you get vasoconstriction, which causes your hands and feet to be cold a lot of the time for other parts of your body to be cold. And what's funny about it, sometimes you can have awfully cold hands and feet, but yet you've got a temperature that's 103 degrees. So you get this hyperthermia at the same time you have cold extremities. And hyperalgesia just means that if you push on your joint that is inflamed, it hurts worse than it should. And allodynia is just the pain that is there if you just barely touch the skin or wave a feather on it, you may cause pain. So these are supportive physical signs that I'm asking medical personnel to look for and patients to know about relative to determining whether their pain has centralized. Now, there is no specific diagnostic test for centralized pain. However, patients that have centralized their pain almost always have hormone abnormalities, and they will have elevated inflammatory markers. Now, it's a little hard to get the inflammatory marker test today, but there are some that pretty well diagnose the presence of centralized pain. And I've just finished some studies on this, and it's not necessary to take them to make the diagnosis or to guide treatment necessarily, but they're nice to have if one happens to be a little uncertain as to whether the pain is centralized. Now, the hormone abnormalities I'm going to talk a lot more about, because the hormone abnormalities may end up with having hormone deficiencies, which then require replacement. And so EDS patients have to know a lot about hormones, both the testing as well as what it means. And the exciting thing about it, there are some what we call neurogenic hormones that are being used to investigate the ability to literally start bringing about some healing of pain in EDS patients. When it comes to the hormones, just quickly, when you have centralized pain, there are two phases to its effect on hormones. The uncontrolled pain, first off, causes hormones in the blood to go up, and therefore you have elevated hormone levels, and those include such hormones as cortisol, estradiol, progesterone, corticotropin, pregnenolone, and some others, which I will show you here in a minute. And then if the pain is not controlled, then your pituitary gland and your adrenal glands and your gonads may start to deplete. And when that happens, pain gets worse, your pain medications aren't very effective, and you'll be miserable because in order to have any kind of comfort, hormones have to be in normal range in the blood. This is a little complicated, but it's a picture that I would like for everyone to know about. What it shows you in the middle are 3 overactivated microglial cells. And if these cells are overactivated, they cause all of the things you see on those arrows. And I'm well aware that many of you watching this can go around that circle and see that you have yourselves a great number of those symptoms or those manifestations of microglial cell overactivation. Patients for years have told me things, and I believed them, but I didn't know what caused it. They've always told me they had memory loss or insomnia or fatigue or depression or decreased attention span. We knew that their hypothalamic and pituitary was overstimulated and their sympathetic nervous system was overstimulated. And we knew that they certainly came in seeking a lot of drugs for relief. And unfortunately, a lot of people who have this microglial cell overactivation try to find medical relief or try to find relief through drugs, and they're usually called a drug addict or given some other pejorative name. And I'm trying to get the medical profession to understand that when they see a patient who has a lot of these signs and symptoms and constant pain, not to look at that person as a drug seeker or a drug abuser, but somebody who needs help and needs an evaluation for centralized pain, as well as other things such as hormone deficiencies. And I'm calling, if you will, for a new day, and that is quit looking at people as drug seekers, but understand that they have overactivated microglial cells. You might find it intriguing, but today we are starting to use the term microglial cell modulator. There are a class of drugs that are being investigated and, in fact, being used clinically today, which calm down these activated microglial cells. Some of them are actually antibiotics, some are hormones, and some are other agents. But one of the new areas of treatment is a class of drugs that we are starting to call microglial modulators, meaning we change or we modulate the activity of these microglial cells to reduce the inflammation and reduce the pain and to increase healing. I thought I would throw this in to make a point about something. We have had in recent years controversies. We have a group of people who are trying to ban opioid drugs in the country. We have a group of people trying to ban epidural injections. We have a group of people who say that pain is all in your head and only psychotherapy should be used. But we have a long-standing standard in pain treatment that's been here a long, long time, and it is still the gold standard, and that is the World Health Organization three-step analgesic ladder. I would like to have all pain patients know about this ladder because this is how you treat people, and this is how you deal with things as to whether somebody needs a higher dose of morphine than someone who needs a lesser dose. In other words, step one in pain treatment is non-opioid pain relievers and adjunct therapy. This means that the first thing you do when you have pain, and an EDS patient certainly needs to know about this, this is where you're going to use exercise, you're going to use topical medications, you're going to use what we call neuropathic agents, you're going to use electromedical things, you're going to use prolotherapy, you're going to use all these things that are not opioids to see if you can control the pain. One of my pet peeves is that I get patients referred to me, and nobody's ever taught the patient how to do exercises, nobody's given them topical medications, nobody's ever told them what nutritional supplements they should take, nobody's told them how to take care of themselves without narcotics or without opioids. And if you aren't making it on these non-opioid therapies, then you need to be given an opioid. And we have two classes, the weak ones and the potent ones. And the weak ones today would include such things as tramadol or codeine or Vicodin or Percocet or something like that. And then if that doesn't work, then you add a potent opioid. You don't give up your topical medications and your TENS units and your exercise. You add to this regimen. And this is the way it's supposed to be practiced. And we've been doing this since the 1980s. But we have an awful lot of naysayers and a lot of people who are trying to deny and state that there is no standards, and that gives them an excuse to either deny people an opioid or to give them too many when they haven't done non-opioid therapies. In other words, we've had this standard since the 1980s. I've been practicing it since then, and I'll continue to do so because that is the gold standard. Patients who have pain need to understand that there is this standard, and if you don't have a copy of this, you should get a copy of it, and all the medical profession needs to, give up the rhetoric and all the condemning of this, one treatment or another, calling people names, and putting this ladder to work. So I wanted to make it clear that good, serious physicians who deal with pain are aware of this ladder and are going to support it. They're not just going to give you an epidural block or a shot or something like that and send you on your way. They're going to follow this as they should. I now want to talk about hormones because this is my area of research, and I've been the one in the country trying to popularize this. And here is why I'm big on hormones, and I will continue to be big on hormones because pain control is hormone dependent. Hormones are needed for four things. First off, tissue healing. You cannot heal your joints if you have a deficiency of one of the major hormones in your body. Hormones help heal joints. There's some new research out, for example, that things like estrogen and testosterone are critical for the growth of cartilage. Secondly, reduction of inflammation. inflammation is controlled by a lot of different factors, but one of them is hormone control. Again, if you don't have enough hormones, your inflammation is simply not going to calm down. I mean, the classic inflammatory hormone is cortisone, but there are others that are almost as necessary to control inflammation. So cortisone is not the only hormone that one must have to control inflammation. Analgesic effectiveness. Now, here is one that's very unappreciated. Drugs such as hydrocodone, oxycodone, morphine, fentanyl, all of the opioids are dependent upon adequate hormone balance to be effective. Most of you have heard about receptor sites. Now, receptor sites are little action points in the nervous system, and a drug such as Vicodin, for example, or tramadol or morphine will bind or attach to these little receptors, but the receptors don't work if you have a deficiency of hormones. In other words, you can't get good pain relief if you don't have enough hormones, because all major pain relievers, particularly opioids, only work when you have adequate hormone balance. And then lastly, neuroprotection and neurogenesis. These are new words. They have recently come forward. 5 years ago, no pain specialist would even have ever utter the word neuroprotection or neurogenesis. But neuroprotection means that you're going to keep what you have. You're going to prevent any deterioration of your current neurons in both your brain and your spinal cord, or even out in your legs or arms or joints. That is neuroprotection. Now, the body produces a number of hormones to give you neuroprotection. And then secondly, the body has something called neurogenesis. This means you're going to take a neuron, and make it grow. It is nerve growth. Now, hormones are required for both of these. There is a fascinating and absolutely essential bit of research that has come out of the recent years, and that is that the brain itself produces its own hormones. They are called neurosteroids. This might shock you, but our own brains produce estrogen, progesterone, pregnenolone, and something called DHEA, plus it produces something called oxytocin and human chorionic gonadotrophin. Now, those 6 hormones are used by our nervous system to not only give us neuroprotection, but they are in our brains to give us neurogenesis, in other words, nerve growth. If you have centralized pain, you must be on a program of pain relief, number one, but number two, you're going to have to be on some kind of a hormonal program that keeps enough hormones in your nervous system to make sure that your nerve cells are protected as well as make some grow. It is the growth of the nerves that allows one to reduce their pain permanently, or at least almost the whole way even sometimes, but at least reduce it, and therefore you need far less medication. So these concepts of hormonal control of pain are critical. And this is one of the things that I want to leave you with today, is that this is the new understanding and the new wave of treatment. I would not want to be doing pain management today with intractable pain cases or with EDS patients without the ability to both test and treat with any number of hormones. Now, today, something else has happened which is wonderful, and that is laboratories throughout the country now have the technological ability to do hormone profiles. Now, literally 3 or 4 years ago, if I wanted to get these 8 hormones tested, I'd probably be filling out laboratory slips for a month and begging laboratories to try to run these tests. Today, you can go to any of the major laboratories and your physician can fill out a simple one-page request form and request these 8 hormones. This 8-panel hormone profile is what I recommend today. There are actually 2 laboratories that have sprung up in the past year that actually cater to pain specialists to do hormone profiles, and more laboratories are on its way. In other words, We could not have I couldn't even be giving this lecture tonight if laboratories had not developed the technology to do this hormone profile on a single tube of blood. So I do want you to know that hormone testing underpins all the hormone treatments, and that the technology is here to have this panel done rapidly in every community in the United States. Neuroprotection. I wanted to put this on here because I get asked all the time by people who don't live anywhere near my clinic, which happens to be in Los Angeles, but I get asked about this all the time. So I thought I would throw this little slide up. This is a little handout that I give all my patients, and I give it to anybody who wants some help, because a lot of people, I am aware, cannot find good medical help in their communities. I think it's a travesty that we don't give good care in every community, but in case you know somebody or you yourself can't find good help, taking some of these things on the slide will at least keep you going. It'll at least give you some neuroprotection, keep you together until maybe you can find some good help. Now, I'm not saying you got to do everything on that slide, but you certainly want to try to do a handful of the things that you see on this slide. And you can buy all these things in a health food store. You don't need a prescription, and this will give you some relief. Let's say you're in some treatment now and you feel you're getting some pain relief. If you add some of these things to it, you just enhance the pain relief you are now getting. I want to close out with this last slide. On this slide are some areas of clinical investigation. Now, when one does a profile like the one I just had on the previous slide, and you have deficiencies of some of those hormones, they need to be replaced. But today, there are two areas of investigation that I want to tell you about. They're very exciting. And I have some EDS patients who are certainly benefiting by these things. The first one is high-potency topicals. Now, what does this mean? This means that these three hormones, when put in high concentrations in a cream and put on your joints or over your nerves, will not only give you good pain relief, but start to, we think, cause neurogenesis. Let me tell you about a fascinating study that was recently done. Some very bright researchers took cartilage that came out of knee transplants. In other words, when you transplant a knee, you open the knee joint and you scrape all the loose cartilage out of the joint, and you normally just throw it away, and then you put the metal in and you sew them back up. But at any rate, some bright researchers took this cartilage and they put it in a petri dishes, and then they started putting different chemicals on the cartilage to see what made cartilage really grow. And guess what the two things were that made them grow the best? Estradiol and testosterone. And so today we are giving a lot of patients today high-potency estradiol, progesterone, and testosterone to rub over their sore joints. And I have some EDS patients, and I hope some of them are actually watching, who are using some of these high-potency topicals. Again, it's a comer, and I think it's of great interest to EDS patients. And the second thing that I want to bring to your attention is neurogenesis and microglial modulation. These two terms I mentioned earlier, but there are two hormones that are starting to change the lives of a lot of people with centralized pain. Human chorionic gonadotrophin is the hormone that the body apparently uses to grow nerves. For example, a pregnant woman will have human chorionic gonadotrophin go way up in the serum. And it used to be thought that it was just there to maintain the placenta, but we now know that it is that hormone that is responsible for the growth of the nervous system in the embryo. And so all of us, when we were in our mother's womb, the chorionic gonadotrophin that was produced was there to make our nervous systems grow. And so that's what it does. That's its natural function. And both men and women have human chorionic gonadotrophin. And we're learning how to use it more and more. We have some patients who have been on this compound as long as 5 years, and they continue to improve their physical systems and they continue to reduce their pain. And the last hormone I want to mention is oxytocin. we're not 100% certain how it works, but EDS patients certainly have, like oxytocin as a group. There will always be some people who will not care for it, but it has at this point been a very helpful hormone for EDS patients, and I highly recommend it that people give it a trial. Most physicians in the country have heard of the hormone, but they really don't know how to obtain it or what dosage to use or what to look for. But I'm hoping that some of that will get changed in the next year or so.
Okay, Dr. Tennant. Oh, sorry.
Yes. I'm finished.
Okay, I was going to say you can go ahead to the Q&A if you'd like to click on that icon. I'm getting a lot of chatter with the live attendees, and they're having many aha moments, and this is new information to a lot of them, so they're very excited. You'll probably be getting a lot of questions. There's about 60 live attendees tonight. Okay. So if you can call up that box and see what you find in the list.
So how do I do this now? I'm happy to
okay,
do whatever you want. All right. All right.
Yeah, there you go. There you go. And then you can use the arrows at the bottom and top of the scroll bar to go through the list slowly.
All right. Question 1. I have a teen on low-dose naltrexone who has daily EDS, tenosynovitis pain in main dominant writing hand and shoulder. She is in pain every day, averaging 7 to 10. Any ideas for daily management when pain spikes? Any medicine or alternative suggestions to help with pain? She cannot take tramadol. Gabapentin doesn't help. Motrin, Tylenol, Naproxen may take pain down a notch, but doesn't want her to take this on a daily basis. Bracing does not seem to help. Well, you are, first off, at this point, you are on step 1 of the World Health Organization ladder. You are trying a lot of non-opioid treatments. If in looking at what you're taking now, certainly, again, if you could get it, you'd certainly want to add some of the high-potency hormones to your joints, and there may be other things that you might be able to do. But in this, I know that it's probably not very available, but in this situation that you're describing here, this is the perfect situation to where somebody should have a hormone profile, and any deficiencies should be replaced, and then the different hormones tried. Also, that slide I put up there on neuroprotection, there's a lot of things there I don't see them taking. I don't see the mention of fish oil or vitamin D or white willow bark or any of these things that can be obtained in a health food store. You don't have to try all those things, but a lot of them would be worth trying. Now, if that doesn't work, a person is going to have to go into the opioid drugs. And, of course, codeine or hydrocodones would be the first place to start. They've already tried tramadol, but the fact that they can't take the tramadol doesn't surprise me, but you may have to go into the opioid drugs. It's always sad when somebody has to go that route, but if you have to, you have to. Next slide. How do you find a good local pain doc? I can say with great difficulty, but let me see if I can get a little bit. It says, I'm not quite sure. Hang on here. Okay. Finding a good pain doc, the only way you can find a good pain doc is to talk to other patients and ask them who seems to care, who seems to know. And now that I've said that, let me be very, very clear. The vast majority of communities in this country do not have pain physicians that will be very capable in dealing with an EDS patient. I'm sorry to have to say that, but that is the way I call it. The pain specialty is populated. 80% of doctors who hold out in this country are PM&R or rehab doctors or anesthesiologists, and they are either interested in rehab or in procedures in the main. There aren't many of us who are basically internists and I think that's a tragedy, and I'm doing what I can to encourage internal medicine and even family doctors or nurse practitioners to try to start learning how to really manage pain medically. But I'm sorry to say at this time, it's not a good situation. Next question. Let's see. It says, I have been taking opiates for the past 5 years. I recently found out I have central sleep apnea. I have been able to lower my dosage to about 100 milligrams of morphine equivalent, all in short-term formulation that I stop early evening and rotate to Lyrica for nighttime. Do you think that will be adequate? I do have severe bone spurs at all levels of cervical spine, especially C3, but my sleep doc still thinks the opioids are playing a role in the sleep disorder. If I wanted to try the neurohormone supplementation for intractable pain, how would I go about doing it? I live in New York City. If I found an endocrinologist who would be willing to work with me, would he or she have access to your procedures? The answer is I actually have a website that I made for physicians, and it's called Hormones and Pain Care. I'm going to start adding a patient section to it, but that website is free to any physician to take a look at it and start learning. I know at Pain Week each year we have a course on hormone testing and treatment. Now, relative to your sleep apnea, it may well be that your opioids have nothing to do with your sleep apnea. In fact, if you're tolerant to the opioids, which I assume you are, I doubt if it has much to do with your sleep apnea. Also, you should be aware of something else about centralized pain. If you have centralized pain and you have to take opioids, 70% of patients who do that have to also take a stimulant. In other words, stimulants do something in the nervous system besides stimulate you, and they may be necessary for pain relief as well as preventing sleep apnea. Let me tell you a little anecdote. In 1895, the physicians at the Brompton Hospital in London recognized that if you had severe pain and had to take an opioid, and they had 2 opioids in those days, morphine and heroin, but they said clear back in 1895, if you're sick enough and have enough pain to need opioid drugs, you also need a stimulant. And the only stimulant they had back in those days was cocaine. But we've got a lot of different stimulants today, and astute pain physicians ever since 1895 have been using opioids with stimulants, and that's one of the ways you avoid side effects such as any possibility of sleep apnea. Next slide, it says here, I'm not sure. It says here, you no longer recommend alpha-stim in your patient manual. Is there a reason for this? Do you have any thought recommendations reissues for pain? Yes. The reason it's not perhaps listed in my manual really probably has to do with the fact that it's included under the generic title of electric currents. Alpha-stim is a microcurrent, very effective, very helpful for a lot of patients, but it is an electric current. Now, what I'm trying to get across to people these days is that you have electric currents for therapeutic purposes, and then you have electromagnetic energy waves. These two are different, and they have different uses. Now, the alpha-stim, and I use it all the time in patients. I have 2 or 3 alpha-stims in my clinic. The alpha-stim has a current that goes into a very small area. We have a lot of other patients who may have a painful area that goes 6 inches across. Well, alpha-stim is not going to do any good there because it only is going to go into an area about a half a centimeter wide. And so these different electromagnetic and electrocurrent devices are used for different purposes. But let me be very clear. I'm a great believer in both electric currents and electromagnetic energy devices, and the electromagnetic energy devices include the lasers, the infrareds, as well as the radio waves, and I use all of them in my clinic. Ultrasound is a sound wave, and it's neither, but it's also got a lot of uses. So all these devices have uses for different people, and I get very upset when I hear that somebody says one device is better than another, or they want to accuse me that I don't use one of them. I use all of them. and they all have a place for different patients. And I think the commercialization of these instruments has made it to where you can hardly talk about these instruments objectively at a conference because everybody is claiming that their device is the only way. That's simply not true. That would be like saying that one opioid drug fits all or one neuropathic agent fits all. It is not true. All of this has to be tailor-made for a patient. Now, if we don't have to tailor-make things for a patient, then doctors like me, we can just hang it up and go home. You don't need us. You need a cookbook. And I think I'm making the point here, and I hope I'm making it very strongly, that you don't want to start raising your hand and say there's one way to do anything in medicine. Each patient needs its own suit of clothes, and you have to tailor-make treatment. And even in a given patient who has centralized intractable pain, that pain may have to be managed over a period of 10, 20, or 30, or 40 years, and the treatment you're using today may not be what you need in a year. And so I think it's high time that everybody quit trying to find the one way. Pain treatment requires experimentation. The best pain docs are those who get together with a patient, and the doctor and the patient say, let's try this program this month. That's the way you've got to do it. There's a lot of art to it, and we can only guide you. You have to try different things, and that includes electromagnetic and electromedical devices. Next slide here. Let's see. Said I had my pain management doc. Run an adrenal panel on me. He did not know what to make of me having low DHEA levels in the presence of otherwise normal levels of cortisol, ACTH, pregnenolone, and testosterone. Can you explain this? Yes, we can. DHEA, or dehydroepiandrosterone, is made in the adrenal glands, in the gonads, both ovary and testicle, and it's made inside the brain. When pain starts to get out of control, one of two hormones start to deplete. DHEA is either one of the first one to go, or it will be pregnenolone. So what you describe is very common. In other words, you're obviously getting some pain control, but it's not as good as perhaps as it should be. And I would highly recommend you start taking some DHEA and bring that level up to normal. DHEA can be purchased in any health food store. Starting dose is around 50 or 20 or 25 or 50 milligrams a day, and you can work it on up to 200 or 300 milligrams a day if you need to. You may find that you feel a lot better and get a lot more pain relief when you bring your DHE level up. Now, again, this is never the same for everybody, but that's the way I would look at this. Your finding is very common. Let's take the next question here. Let's see. I can't quite read this, and it's not wanting to go too well. I have really bad leg aches. Is that part of EDS type 3? Leg aches can be part of, any painful condition. And exactly what's causing the leg aches can be really quite variable. So it would be hard to tell you what's causing it unless one was examined and knew a lot more about the case. But leg aches can be part of a centralized pain syndrome itself. It can certainly be part of any kind of a neuropathy. It can be part of any kind of a spine condition. So it certainly happens. And again, leg aches should be looked at as a pain and treated as such. But it would be very difficult to stand here and say what to do about any kind of a leg ache. You have to know the cause of it. Next question. How do you find a physical therapist that knows about EDS? Everyone we have dealt with has pushed through pain philosophy and causes more pain damage, not been helpful. This is an excellent question. I believe that before a EDS patient goes to a physical therapist, trainer, chiropractor, anybody who does physical manipulation, your physician should know about it, and you'll want to consult with other patients. I'm like the person asking this question. I see as many people damaged by these therapists as I do helped. You must be awfully careful. I've seen EDS patients be terribly damaged by well-meaning therapists, and they just didn't know, and they want to do way too much stretching, way too much weightlifting. And let me just say this about any kind of physical therapy for not just EDS patients, but anybody who has serious pain. You only want to stretch your arm, your leg, or your joint to where you feel a tug, not cause pain. The old saying, no pain, no gain, works in normal people, but when you have centralized pain syndromes, that is the worst thing you can do, is try to cause pain, because then what you're really doing is pulling apart scarred nerves, or you're doing something to the tissue which will backfire on you and probably make you worse. Could you comment on whether medical marijuana is showing any promise for EDS pain? I have no comments about medical marijuana, and it would be inappropriate for me to do so, because I have no idea what dosage people are buying. And I think for any reputable physician in pain work who would recommend medical marijuana is ill-advised. I wouldn't, it's not just marijuana, this would be DMSO or some hormone or anything else. If you don't know the dosage of what a patient is taking, don't recommend it. Now, I think that the molecule of marijuana, the cannabinoids, have a place, and I think they will have a place in line medicine at some point. But you'll see me recommending cannabinoids for use when I know the dosage, and I've seen studies showing exactly what kind of pain it will work for and what it's good for. So don't put me in the column of not supporting the current medical marijuana combine, because all it is a bunch of people out there in stores selling something called medical marijuana. They don't know the dosage. They don't know what the blood levels are. They don't know what it's really doing, and I don't think any physician should participate in this. When FDA licenses a cannabinoid with a good dosage, and the studies have been done like any other drug, count me in. I'm sure I'll be prescribing it, but not until then. Zero gravity Epsom salt sensory tanks, do you think that would help with pain? And how long would you soak and how often? The answer is absolutely, I think it will help. Water therapy has gone on for centuries, and it's been quite effective. We're not really 100% certain how it works, but let me say this. At its most fundamental level, pain is too much electricity in one spot. Now, electricity is an even distribution of electrons and protons. When you get in the water will change the polarization of electricity and will start pulling electricity out of the body. And therefore, it works good. Now, if you put some Epsom salts in the water or some other kind of salt, you just increase the ability of the water to pull out electricity. And this is why for centuries people have been getting in hot baths with salt in them and getting a lot of relief. I would hope that every EDS patient would have access to a sauna, swimming pool, a big bathtub, something to soak in. EDS lesions are all over the body, and so soaking is great. How long? I know of no good time period. My guess is that you can get most of the good done by soaking within 5 minutes. But again, I don't know that anybody really knows how long, but I do know that 5 minutes in soaking will probably pretty well maximize what good you can get out of it. But I highly recommend Epsom salts and soaking, whether it's in a bathtub or whether it's in a swimming pool or a hot tub or whatever. It says, do you think medical marijuana, cream, oil, tinctures, and or vapor would help EDS pain? Again, anything with marijuana at this time I won't comment on because I don't know the dosage. If I knew the dosage, maybe I could answer the question. It says, let's see, it says, if pain from damaged joints, would surgery correct pain? How would you find a surgeon that understands this? Surgery in EDS is something I will not claim to be an expert in. My general thoughts are this. I would not be much of a supporter of surgery unless there is a joint that is really loose and just flopping, or that you have developed an entrapment syndrome. Again, before I would have any surgery operate on an EDS patient, I would want a surgeon who is familiar with EDS and who has previously operated on EDS patients. I've seen surgeons who meant well, including good plastic surgeons, damage EDS patients simply because they did not understand what they were getting into. Again, talk to other patients, find doctors who know something about EDS. Don't just go off the farm and look up somebody in the yellow pages and hope things are going to work out. It may not. What is the difference between centralized pain and fibromyalgia and EDS? Well, fibromyalgia, first off, is a condition in which the muscles ache. And there's a lot of causes for it. There is the belief by some people that fibromyalgia may arise on its own inside the central nervous system, and it therefore is a central pain. And so that's fundamentally pretty much the same. Now, and EDS is primarily a peripheral arthropathy, neuropathy condition that sends pain signals into the central nervous system. And so what happens with EDS, you have both centralized pain as well as peripheral pain, and both have to be treated. Both the periphery and the central has to be treated. So there are similarities between all of these things. If a comprehensive pain management center is not helpful, where does one turn? Rheumatology, neurology, and my answer to that, again, is you've got an association, you've got friends, you've got people with a condition who want to help not only themselves but each other. And I think you simply are going to have to try to put together a list of people that can help. It's very difficult. There is no magic way out of this. I am not happy with either the medical profession, the medical schools, or the government, because they have had this idea that anesthesiologists who do nerve blocks and epidurals are pain specialists, and that's all we need. And that is not true. We need to have internal medicine specialists who know about heart troubles, know about rheumatology, neurology, endocrinology, who know a little bit about all of these things. So it is my fond hope that we'll have other internists like myself who know something about these different areas get into this business so we can develop some true specialists. And I will say this, that we're making some movement along this line. I think what your association is doing is a darn good first step. These webinars are great. I listened with great intent when I heard that, yes, it's expensive to have everybody get together at a conference. That's even becoming not just an issue for patients, but also for doctors. I've exhausted my resources without pain meds, exercise, acupuncture, cranial, sacral, topical, PT, diet, supplements, etc., but I have such severe stomach issues that NSAIDs are not an option. Are there any other options? Cortisone, yeah. Well, NSAIDs, if they work, great. If they don't, there are many other options. Today, again, looking at that step one of your World Health Organization ladder, there are a number of new things that are not opioid that one can try, and most physicians in the country are fairly comfortable with these. The class that the doctors talk about the most is one called neuropathic agents. Now, neuropathic simply means that the nerves are damaged. And there are some very popular drugs that are in that class. One is Lyrica, one is Zymbalta, one is gabapentin, and then you have some older drugs in the benzodiazepine class, such as Klonopin and Valium, Ativan, that can be very helpful. I know it's a little controversial, but a lot of EDS patients are going to have to go to Soma. It's a non-opioid drug. It can be abused, but nevertheless, it can give great relief for some people. Ketamine is a newcomer out there. Low-dose naltrexone is new out there. And again, the hormones. Again, before someone has to get into NSAIDs that are going to upset your stomach or get into opioids, I would hope patients can have the benefit of a hormone profile and somebody who knows how to administer replacement dosages, and really, and even better, to find physicians who knew how to administer some of the new neurogenic hormones, such as oxytocin and human chorionic gonadotropin. Cortisone shot set off my daughter's complex regional pain syndrome, burning. Does this mean other hormone shots might do this? The answer to that is probably not. Again, she was given a cortisone shot. I don't know why they gave her a cortisone shot, because the cortisone shot could have been into a joint, it could have been into the nerves. It may have been a cortisone shot that was meant to be systemic. In other words, you have to know what was the cortisone, why was it given, where was it given. Otherwise, it would be a little hard for me to say this. Why? She's got complex regional pain syndrome, and so cortisone shots in complex regional pain syndrome are rather hazardous, and you'd have to know why you're giving it. Most physicians, like myself, I'm very leery of giving any cortisone shots anywhere around RSD. On the body. For example, somebody's got RSD on the hand or on the leg. Not many physicians who are familiar with RSD are going to give a cortisone shot in that limb. So that's not something that's normally done, because you know that it's going to set it off. So, again, that's something that, I'd have to know a little more about it. But in general, cortisone shots near regional pain syndrome issues or lesions really shouldn't be done in. Next one here. So if hormones have been tested and they are normal, what is the next step in pain control? Well, if your hormones are all normal, you're very fortunate, and therefore you can pretty well take any other kind of pain medications you want to do so. What I like to do in patients that have normal hormones, that's the very best patient to administer oxytocin or human chorionic gonadotropin, because these other hormones work through your normal ones that can be tested. The person, if they have centralized pain and their hormone profile is normal, that's good news. They've got an opportunity to try any number of therapies. What are the most common best tests to check my let's look. I'm sorry, I'm losing the question is not coming back up. Here we go. I think the question was, what are the hormones best tested? Let me see if I can get the exact question up here. Yeah, what are the most common best tests to check my hormone levels? I gave you the profile that earlier on a slide, in which there were 8 hormones there on that slide, and I think they could probably get you a copy of those. If anybody wants to, they can certainly go on our website on hormones and pain care and look at it. As of yet, we don't have a patient section. It's really there for physicians, but most EDS patients are pretty sophisticated, and I can tell that by your very questions. So you can probably get the information off that you would like. Also, feel free to drop us an email. We try to answer everybody's email that we do get. and we think that's one of the very best ways to disseminate information. Let's see. Next question here is human chorionic gonadotropin available to physicians in Ontario, Canada? I've had a number of calls from Canada, and as of yet, I don't know that anybody in Canada has been able to get it. I do not understand the Canadian system very well, or how people are taken care of. Human chorionic gonadotropin has been a controversial agent because it's been used for weight control and for sports enhancement, and a lot of people are somehow afraid of it. But gee, it's quite safe and easy to use, and I would hope that people in Canada could avail themselves to whatever is in the United States. It says, method for getting HCG and oxytocin, is it through injections? Is this what Suzanne Summers takes? Well, Suzanne Summers hasn't consulted me, but I would not be surprised. A lot of the celebrities are able to get the very best in hormone treatment. And Suzanne Summers, I do know this, is very big on life extension. She has some great material out, and I think she's done a great job of educating. Many of your anti-aging physicians use these hormones. However, let me caution you, they use them differently than we do in pain management. Our dosages are different, our routes of administration are most likely to be different, and our indications. Anti-aging physicians have a total different way of going about this, and I only recommend that hormones be replaced when you've had a blood test, and I only recommend that HCG and oxytocin be used in very controlled circumstances. For that. Now, it just says the method of getting HCG and oxytocin is it through injections. HCG can be taken either under the tongue or by injection. Oxytocin is either taken under the tongue or by nasal drops. It is not given by injection as far as I know. Next question, why would glutamine in particular be helpful for pain relief? In the central nervous system, you have several major chemicals that help control pain. One is, of course, endorphin. Another is dopamine, and another is something called gamma-aminobutyric acid, better known as GABA. Now, GABA is the chemical in the nervous system that inhibits or holds back electric transmission. If you have too little GABA, you have too much electricity going up and down your nerves, and that's when you're going to get hypertension, you're going to get allodynia, you're going to have tremors, you're going to feel very nervous, very anxious, and so you need gamma-aminobutyric acid or GABA. Glutamine is the amino acid that makes GABA, and therefore a lot of people can take glutamine and it will make GABA. Now, pain control, as the body sees it, requires endorphins, it requires dopamine, and it requires GABA. GABA is not as well known to the public as perhaps endorphins or dopamine, but from a point of view of pain control, it's absolutely essential. For example, you've heard of gabapentin, that's just an analog of GABA. You've heard of Lyrica, that's just an analog of GABA. You've heard of duloxetine or Cymbalta, that's a derivative of GABA. In other words, the whole pharmaceutical industry knows all about GABA, and so they try to mimic GABA with very expensive commercial compounds. And you can sometimes duplicate the same thing by going down to the health food store and buying a big bottle of GABA. You know, it might cost you $5 or something like that, and you may need to take 3 or 4 a day, but sometimes you can get just as much out of some glutamine as you can out of gabapentin or Lyrica. In other words, you can save a lot of money and maybe get the same thing done. Next question, do you only recommend hormone creams if our levels are low or always an EDS patient with centralized pain? If so, do you recommend all 3 of those you listed in one cream? The answer is, I don't know. It's too early. At this point, we've not tried to mix the creams. We've tried to give one to a patient. We give them estradiol or we'll give them high-potency testosterone. Incidentally, the high-potency, for example, the testosterone that we use for topical for joints and for EDS pain, for example, has a concentration something like 10 times that which is used by males for hormone replacement. And again, it says here, do you recommend hormone creams if our levels are low? The topicals we don't mind using regardless of what the hormone levels are, because we're not getting it into the bloodstream to any extent. We're trying to get the hormone into the joints and into the muscles and nerves. They're in the periphery, so we're not too concerned about what the blood levels happen to be. Now, I might come back and have to give you a little different thought here in a year, since this research and investigation is a little new. It says, I currently use different pain modalities, heat therapy, pads, TENS, inferential treatment, regular massages, dry needling, etc. I am also prescribed 30 milligrams OxyContin daily. My pain management doctor has prescribed a compounded topical cream with various ingredients, including ketamine. Unfortunately, my insurance, Express Scripts, no longer covers compounds made with powdered substances. I read your Intractable pain booklet and saw that you sometimes recommend mixing morphine with body cream to use as a topical. I asked my pain manager doctor to prescribe a couple of morphine pills for this purpose, but he's refused to do it and won't discuss why. I have been going to this doctor for a few years now. I have a good relationship with him, and I have not violated my pain card in any way. Your thoughts or suggestions? Yes, I have some thoughts and suggestions. The insurance companies today are starting to not cover anything that is compounded. They're tending to not cover, any brand names. They are ratcheting back on all kinds of products. And on the other hand, there's now high deductibles and their cost. The topical morphine is a cheap fix, if you will. People, in my own clinic, I teach people to make all their own creams. We buy our creams at the 99-cent store, and then we try to get the raw tablets or something to make our own. Why a physician in this day and age wouldn't be willing to give somebody a dozen morphine tablets to crush up and put in a 99-cent jar of cold cream befuddles me. It's a very inexpensive thing to do. That's why I'm so high on people learning what's in their health food store, what they can make themselves, and to start exploring alternatives to these expensive name brand drugs or these compounded drugs that the insurance companies just don't want to cover. Unless there is a new attitude among the insurance companies, I think we all have to keep looking for a better, cheaper way. And let me bring one other thing to your attention that you may not have thought of. The insurance companies today are spending so much money on the hepatitis C drugs and on the biologicals and cancer drugs that there's not much money left over for a plain old pain patient. At least that's what is being written about, at least in some of the investment literature. Bottom line, again, I believe that it's up to every one of us to try to find inexpensive ways to get better treatment, and once we come up with something, let's share it. So the sooner we start to manage and control pain via hormone, salt, etc., meds, the better. Absolutely. I take patients who are way down the line. Some of them are very tragic, and it's sad. I have often believed that if we could intervene right when pain starts, right after the surgery, right after the injury, right when an EDS patient starts to get pain in their joints, even if they're just 10 years of age, we should start trying to intervene and start trying to control the pain the best we can. Just remember, centralized pain is an inflammatory process that gets worse over time. The sooner we get started, the better. And what do you start with? It doesn't make a lot of difference because you're going to try different modalities to start with. You may change those later on. And so you have to experiment. You try to find what works for you. What works for you may not work for me or work for the next guy or gal. But that's the way you go about it. And you want to try to find physicians, nurse practitioners, pharmacists, and other medical people who will work with you. Next slide. Pain doc or endocrinologist help with the hormones. I think you find anybody who is sympathetic and who cares. In the general, most of your endocrinologists are so busy taking care of diabetics and thyroid problems that they're probably not going to be too terribly interested in helping a pain patient, although some are. and that's great. But it is my goal, and what I'm trying to do is to take any physician or nurse practitioner, PA, pharmacy in this country who is interested and show them how to use the hormones in pain patients. We're not going to make pain physicians endocrinologists, but in our narrow area of hormone testing and treatment, it's simple, it's easy, it's a lot safer than giving people gabapentin, Vicodin and ketamine. So hormone treatment, some people might think it's dangerous or difficult. It is not. It is really quite simple. I've been at it a long time, and I've learned that I can teach it to practically anybody, and it's sure a lot safer and easier to do and a lot cheaper than 90% of the things we're doing in pain management right now. Okay, what about garlic for pain relief? Give it a go. Some people find that whatever's in garlic has some pain relief. And if you get pain relief and don't mind smelling bad, hey, go for it. Nothing wrong with garlic. Next question. I am a young lady just recently diagnosed with EDS, hypermobility. My pain symptoms began after a minor car accident, and now I have body-wide chronic pain. How can physical traumas trigger EDS? Any kind of trauma may set off those microglial cells. And if they set off the microglial cells, then a chain of events may occur. That may include fibromyalgia-type pain. It may include an autoimmune reaction. It may trigger off things like too much sympathetic discharge. In other words, there is, for reasons that we don't quite understand, trauma can set off everything. You can go along in your life and never know you have EDS until you get to trauma, and that does happen. I can't give you all the exact details of how it happened, but it certainly does. You're not unusual. I'm in perimenopause. How do I get my hormone levels tested at a time in my life when they're fluctuating all the time? Well, first off, it's signed by Zach Martin. I take it that Zach, in this case, is a woman. It's a pretty woman's name, so I hope I'm talking about a woman here, although men may have perimenopause also. At any rate, first off, keep in mind that testing hormones in pain patients is quite different than testing somebody who is going through menopause. They are not equated. Let me repeat and be very succinct about this. When I talk about hormones and I make comments about hormones, including dosages or usages or routes of administration, I'm talking only about chronic pain patients. You would have to talk to a gynecologist or an endocrinologist about perimenopause per se. You'd have to talk to a gynecologist about something to do with fertility. You'd have to talk to a urologist about, testosterone replacement in older men. I'm only a pain specialist, and I only have expertise in dealing with pain patients. Now that I've said that, if a person in perimenopause has chronic pain, I test them, and I will go right ahead and administer estradiol or estrogen or testosterone or progesterone if those blood levels are low. I forget they're in perimenopause and administer those hormones because I know that pain's not going to get any better if I leave somebody walking around with low hormone levels. Is a transcript of this presentation available? Beats me. John, I hope you're listening. I hope you can make it available. Anything I say, you're certainly welcome to. I don't have any proprietary hold on anything that I teach or preach. Is it worth it to visit you in California for consult? Would you prescribe for someone in the Northeast? Would you do a phone consult? The question is, the answer is no, I can't do phone consults except in this way. I talk to a lot of physicians, some every day around the country, and I'm more than happy to share whatever I can with someone's physician. It is complex. It is just complex enough that for me to be just on the phone and tell somebody about their hormones is just not something I can do. far as coming to California, it's expensive. We do see some people. I think that a better way to go is to try to find a medical practitioner that you can get along with, your family doctor, your nurse practitioner, your psychologist, or what have you, and I could perhaps give them some tips on how to go about things. Do I see people on consultation? Yes, we do, and I try to take the very worst cases. And unfortunately, I'm sure there's some people listening to this who need the very best of pain care. So feel free to contact us. We're here to try to help. Next question: what type of physician would order the hormone test panel? Would you need an endocrinologist to read those results, or would a rheumatologist be able to read the results and prescribe the hormone therapy? Once a physician, whether they're a rheumatologist, general practitioner, nurse practitioner, take a little training, they can take the tests and interpret them and take appropriate action. For example, this fall at Pain Week, we hope to maybe even give a certificate. In other words, if you haven't taken a class and haven't been given some instructions and maybe a workbook, it's very confusing to a physician, and they are going to have a difficult time. They'd have to be walked through it with their handheld. But at this point, I don't know that any just plain rheumatologist or endocrinologist would know enough about pain. It is such a small area in medicine in that pain and hormones it's a little corner of endocrinology. It's a little corner of pain practice, very necessary, but any doctor, nurse practitioner, PharmD, PA who is interested can learn how to do it. It's not that difficult, but they do need some instruction. They're not just going to be able to do it on a wing and a prayer. I've been drinking Shaga tea from the birch tree. I'm allergic to anti-inflammatories, and this tea helps. However, information is mixed in society that may be harmful to certain syndromes. The birch trees, the white willow bark is, I'm not 100% certain what a birch tree is, so I'm afraid I can't be too terribly helpful. It says I am allergic to anti-inflammatories, and this tea helps. If the normal anti-inflammatories cause you to have an allergic reaction, keep looking for other things, some of your herbs and things like this. Again, fish oil is a darn good anti-inflammatory. I would take a look at that. Vitamin D is a good anti-inflammatory, and certainly some of the hormones. So if you can't take anti-inflammatories, look elsewhere. But you are going to need something that's anti-inflammatory. What type of bed and or chairs do you recommend to increase comfort? Almost every part of my body hurts when I'm trying to sleep, and I rarely get a good night's sleep. My desire is to surround myself with soft pillow-like materials such as good feather bed and comforters, but would that ultimately make my pain worse by taking away the support my body needs? My belief is no. I believe that you want to stay away from pain. And if it takes a feather bed, do it. There is no evidence to me, my knowledge, showing that a soft bed causes you pain down the line. But we do know that if you do lay on your joints and you cause pain, hopefully you wake up and don't sleep too long to cause more of a crush injury. So waking up with some pain sometimes can be a blessing. Bottom line, I like the idea of the softer the bed and the softer the pillows, the better, because you're not going to get crush injuries with EDS. I believe that the whole comments about you need hard wood beds, I've seen people get plywood under their mattresses, and then they wake up in the middle of the night with pain because they're crushing a joint. Try never to crush a joint, because that means you are crushing nerves, you're adding to injury, you're adding insult to injury. In other words, a good feather pillow, go for it. The softer the better, don't cause pain. Since my daughter, age 6, has EDS type 1, I am interested in pain management from a child perspective. If a child already has pain, it's even more incumbent to get on an exercise program. The basic exercise for pain is stretching. Stretch and hold, they call it. Some people call it range of motion exercises. But you want to fundamentally extend an extremity to its full length and hold it there for a count of 10. And you want to move your arm around not in abnormal positions, but in the normal physiologic position. Also, if I had a child at age 6 and I thought they were starting to develop some pain, I'd certainly invest in a hot tub, a jacuzzi, swimming pool. I'd certainly try to start getting that child into water and teaching them to swim, as well as know about the benefits of water. But again, try to do anything one can to keep pain from occurring in children who have EDS. Next question, how would puberty affect the hormone panel? Dramatically. A lot of hormones don't show up in children. They show up only after puberty. I am no expert in this. Some pediatrics or pediatricians are, but I only can tell you a whole lot about hormones in people who have chronic pain. But puberty certainly does change hormone levels, and the person who, if you need to know more about it, who would know about it, would be a pediatrician, and there are such a thing as a pediatric endocrinologist. I've tried tramadol, opioids, Vicodin, and Dilaudid, but feel so sick from the side effects. The drugs don't always help my pain. My doctors have tested all blood levels they can think of, and everything is always normal. I have tremendous chronic fatigue. What are your thoughts? Based on what you have written here, you would come under the category of a treatment failure of standard methods. One of the reasons I put that World Health Organization ladder here today is to let people know that when you have gone up that ladder and you are not getting pain relief, then you are what I call a treatment failure of standard methods. Now, this is the kind of thing a medical pain specialist like myself specializes in. In my opinion, you need to be evaluated, first off, to see if you have centralized pain, and secondly, to see if you have what's called opioid malabsorption. There are a lot of people who have conditions in which the opioid will not get from their stomach or intestine into the blood, and you'll have to take these compounds by a non-oral route. You also may have to get your genetic test done to see whether you have abnormalities in your cytochromes or in your receptor sites or your enzyme levels. And you also need a hormone profile. In other words, you need to know why are you not responding to standard treatment. That is kind of where you are at. This is one of the biggest needs in the country, and you are going to have to find a pain specialist who knows how to evaluate somebody who is failing standard treatments. Incidentally, we have a session, or we had the first edition of an article on failure of standard pain treatments in the January-February issue of Practical Pain Management, and the second chapter will be next month. It would be worth looking at that. I have tested all blood. Oh, here we go. If we are taking pain meds, can we still take fish oil and the other things you listed? Absolutely. Absolutely. There's no contraindication. In fact, they go together. If you have chronic pain, you want to think in terms of putting together a program or a compendium of things. What's going to work for me won't work for you. What will work for you won't work for the next person. In other words, put together a program of supplements, exercise, hormones, analgesics, muscle relaxants. Put together a program. And your program, will be different than somebody else, but that's what you need to do. What are the new stimulants? I feel this may be why I did not tolerate hydromorphine or Contin. The new stimulants, well, there are several on the market. The one that is probably the most popular is one called Adderall. That's a trade name, but it's got 2 or 3 different stimulants in it. Another one that's quite popular in pain patients is plain old Ritalin. Dextroamphetamine is very popular. Some of the weight control medications like phentermine or phenmetrazine are good stimulants in some patients. And you have something called Provigil or Nuvigil, and those are also stimulants. they would be quite good. And incidentally, I'm a great believer in drinking caffeine if one is a pain patient, because the caffeine is a stimulant and it also potentiates other pain relievers. If you are not able, let's see, if you are now, I'm not quite sure NORA means, or low progesterone pill, will that affect outcome of hormone testing? It may. Hopefully it would mean that your hormone test would come back showing a normal progesterone level. There are a lot of women in particular who have been on various birth control pills or measures, or people who have taken various estrogen preparations for postmenopause symptoms, patches or pills. And frankly, a lot of times these people have done very well with their pain because the hormone may be treating more than one thing. Do you think the far infrared heating mats, BioMat for example, are more effective than regular old-fashioned heating pads? And the answer to that is yes, I do. The infrared light is actually not just heat. It is actually an electromagnetic energy wave. That means that that energy wave is half electronic and half magnetic. And so the infrared has a curative therapeutic element to it that you don't get with just plain heat. Bottom line, yes, infrared is a great favorite to me. And I also like to have people get one of the very inexpensive infrared devices and put their hormones on the skin and then put the infrared over it. It drives the hormones in, and people get a lot of relief with that. Let's see. I have dysautonomia that disturbs my sleep. My husband's loud snoring and movement amplifies my sleep disturbance to the point that often I cannot get restful sleep even after he leaves for work. It seems my adrenaline won't let me fall into sleep and have chills. My nervous system seems on high alert and over-responds to any noises to the point that sometimes I feel a spasm in my ears in response to a noise or a mild static electricity sensation from my ear to into my head. I sleep with white noise, dark curtains, etc. I'd rather not move to a separate bedroom, but I cannot function. What is the prognosis if I continue with this sleep environment? Am I harming my nervous system? What you haven't told me here is whether your dysautonomia is due to centralized pain or not. If it is due to pain, I can give you some remedies. If it is due to some non-painful condition, you'll need to consult a neurologist. Now, I'm going to assume you have centralized pain and dysautonomia. Then I can give you some ideas. Patients who have this kind of dysautonomia and have centralized pain will have to take some of the neuropathic agents and some of the benzodiazepines. Otherwise, you will continue on. Now, which agents are we talking about? Some are controversial, but this is what you have to use. Let me talk about the oldest one and as good as any today, and that is plain old Valium. And drugs in that class of benzodiazepines will have to be used to control severe dysautonomia of centralized pain. What is the underlying part of it? Well, it's that GABA I was talking about a while ago. You certainly wouldn't go wrong by going down to the health food store and not only buying some glutamine, but buying some taurine. Taurine also helps make GABA, and taurine and glutamine, they're the usual dosages to control dysautonomia is about 500 milligrams 4 times a day. Again, those are cheap, inexpensive, rapidly available things you can try. But your prescription drugs that will have to come from a class of drugs in which you have Soma, which you have Valium, which you have Lyrica, which you have gabapentin. You will need to have drugs in that class in order to control your dysautonomia. Your thoughts on cortisone injections. Cortisone injections are of many, many types. And in pain management, we can't get along without them. We use them in a variety of ways. Now, let me talk a little bit about cortisone, the basic types of cortisone injections. The controversial one today are epidural injections. Cortisone is put into the spinal cord canal by an injection, and they're called epidural injections. These have caused arachnoiditis. Some of them have been contaminated and led to meningitis. So they're very controversial, needed in some people, but that's one thing that's been an area of controversy lately. The other kind of cortisone injection that's well talked about is what they call intralesional. This is where cortisone is put into a joint or it is put into a painful area. These are normally quite safe, easy for a physician to do who's experienced, and they can be a godsend. Sometimes your painful joint or your tendonitis or your sprains just won't respond except to a cortisone injection, so they are absolutely essential. Now, the third kind of cortisone injection is where a cortisone preparation is given to get into the bloodstream so it will circulate around and calm down inflammation either in the spinal cord or the brain or maybe in a joint. And so all three are needed at times. Physician experts are the ones who should give these things and know when to use them, how to use them, and how to use them safely. Unfortunately, we've had a lot of physicians not know much about them and give the wrong kind of cortisone, the wrong dose to the wrong patient at the wrong time and have experienced complications. But to the competent physician who knows his trade, the cortisone injections are absolutely essential in many clinical situations. Is elevated SED rate related to increased pain? The answer is yes and no. As a rule, yes, at least in chronic pain patients. Anybody with chronic centralized pain who has a high SED rate really is probably going to have extra pain, and they need to bring that sedimentation rate down. Sedimentation rate that is high simply means that you have chronic inflammation, and it needs to come down to normal, and the physician and the patient should work together to try to find a way to do that. Sedimentation rates have been around for almost, about 90 years, but it's still a wonderful test, simple to do, cheap, quick, but it's still an awfully good guide to good patient management. I still take sedimentation rates routinely on patients, and if it's elevated, I go the extra mile to try to bring that down because I know if I don't, pain will worsen. SED rate, bring it down, whatever it takes. How to get approved for home water baths and soak tubs. I think you're probably talking about getting it approved through insurance. And what I do myself is I write a prescription. And I sometimes put it on my letterhead, sometimes I'll put it on a prescription pad. But I do prescribe tubs and hot baths, both either at the physical therapist's office or I'll try to get a hot water bath brought into someone's home. Again, a physician may feel uncomfortable doing it, but I think they look at it wrong. A hot bath or a tub, water bath you can have at home, to me, is a therapeutic necessity for EDS patients, and I would highly recommend it for almost everybody. Would acupuncture or would acupressure be okay for EDS patients, or could that injure an EDS patient? Nothing wrong with acupressure, except under one condition. You don't want to press on a joint or a tendon or a nerve hard enough to cause pain. As long as it's a nice gentle pressure, acupuncture can be quite helpful. So can a good massage. In other words, acupressure works a little differently on the meridians or on the electrical system of the body, but good old massage, you can't beat it. I mean, you can massage hormones in, you can massage in anti-inflammatory agents. In other words, acupressure and massage are both things that are pressure, but they increase circulation and they may also help with the electrical control. I highly recommend it. I find weather affects my EDS, especially change in pressure. Have you seen this in other patients? Not just EDS patients, but people with arthritis and joint problems and with cartilage degeneration have been noticing weather changes and the fact that weather changes cause pain, and they've been noticing this for thousands of years. It's thought to have something to do with bariatric pressure, but nobody quite understands it, but it certainly is a fact. And I always like to have somebody around who tells me their knees start hurting, because this way I know it's going to rain or something. And it's not just a joke. People really do know this, and some people are extremely sensitive to it and can literally tell you when it's about to rain. What are the two labs you mentioned that are doing the hormone testing? The two laboratories that cater to pain specialists, one is Ethos Laboratory, which happens to be located in Cincinnati, right with your headquarters, and the other is Castle, and they're just starting, and they are in Georgia. You mentioned that you would be publishing much of this info soon. Will you be including information about EDS as it pertains to chronic pain and being a heritable connective tissue disorder involving faulty collagen? We hope to. What I am hopeful is that this new research showing that hormones cause cartilage growth becomes a real asset to EDS patients. That is my hope. My early trials to date indicate that it works. And sometimes, somebody that's missionary like me sees something that really seems to work initially, but then, 50 patients later, it's not doing so hot. Well, at this time, I'm very enthusiastic and very missionary about it. So I do think that the connective tissue disorder in EDS will partially respond to these high-potency hormones, and we'll just all keep our fingers crossed, and we'll go from there. Just one little thing about where I first got onto this. Years ago, I was giving a lecture to a group of other upscale physicians in Palm Springs, and I noticed that there was a man and woman who were not particularly dressed too terribly well, and in fact, they kind of looked like they were workers of some kind. It turned out they were a nurse practitioner and pharmacist who ran the Migrant Health Center down in Indio, out for the migrant farm workers. And they wanted to talk to me afterward, and so I stayed around and had a drink with them, and they were a delightful couple, very dedicated to the farm workers. But they told me at that time that they had been putting progesterone cream on knees and essentially curing arthritis of the knee with progesterone cream. I found this somewhat shocking at the time, but I came back to my own clinic, got some progesterone, put it in cold cream, and I've been using it ever since. And I didn't know why it worked until lately, and the lately is that the new scientific studies show that cartilage responds to hormones and will grow. Again, this is an area that EDS patients really need to stay on top of. I'm very hopeful that it helps a lot of us. How much turmeric do you recommend? The dosages on things like curcumin and on turmeric are not known. In general, when you go to a health food store and you get one of these things, again, in general, about 4 dosages a day as to what is in that package will probably get you a pharmacologic effect. Now, here is the problem with going to a health food store. It gets back to some of the things I said about marijuana. In a lot of these things that are in the health food store, we may not know what the dosage should be. But in general, you'll get a physiologic effect with about 4 dosages a day of whatever is in the bottle. Now, there's exceptions both ways. For example, carnitine, which is a top-notch amino acid that a lot of people need to take, 1 or 2 dosages a day may be plenty. On the other hand, you may want to take fish oil 3 or 4 times a day. So it varies a little bit, but in general, about 4 dosages a day of anything in a health food store will usually get you a physiologic effect, in general. I use multiple pain medications as well as other therapies, heat, water, exercise every day, but I'm still dealing with pain that can become overwhelming. I'm currently on gabapentin, diclofenac, and tramadol. What would you suggest trying next? Again, if you were sitting in my office, Paula, you would get a hormone profile, before the sun came up many more days. And we would go from there and to see if we could use hormones to make what you're now taking work. Keep in mind, something I said a while ago, and I'm glad you asked this question because it gives me a chance to repeat a critical point, and that is that gabapentin, diclofenac, and tramadol, particularly tramadol and gabapentin, need normal hormone levels to work. Let's say your estradiol, your cortisol, or your pregnenolone or DHEA, one of those hormones is low, chances are your gabapentin and tramadol is not going to work very well. So that would be one of the first things that I would do. If your hormones are normal and you're being overwhelmed with your pain and disabled, you simply may have to go to a more potent opioid, and don't be afraid of it. If you've got to do it, you should. One other thing about opioid drugs. When you're taking tramadol, that's the weakest opioid, and it's usually got no side effects, safe, easy to take. Take your blood pressure and your pulse rate and see how much you sweat and see if your hands and feet are cold. If your pulse rate goes up a lot and your blood pressure goes up a lot, you probably need a more potent opioid drug. Remember that. You don't go to opioid drugs just because you have pain, but you go to it because you have these other symptoms of sympathetic discharge. I'll take two more questions, then I'm going to have to sign off. I'm giving a lecture to physicians tonight, and I'll try to teach them the same thing I'm trying to pass on to you. My wife's doctors tell us all the time about how important exercise is for her. However, it's the chicken and the egg. Her pain is often triggered by even the smallest amount of exercise. How do we get past this dilemma? Well, first off, there's all kinds of exercises. Now, when people start talking about exercises, they usually start talking about you getting on a treadmill or starting to run a mile a day or lifting weights. That's not what exercise for pain is. Exercises to prevent pain are very simple, and it's what I talked about a while ago. It's that range of motion. You're going to stretch out your arm or your leg and your fingers and hold it there for a count of 10. But do not exercise of any kind, whether it's weightlifting, whether it's running, walking, or whatever, if it causes pain. Stop. Do not produce pain with exercise. And if you find that walking too much just tires you out and gives you severe pain the next morning, cut back. Work up to it. Don't let someone talk you into doing a bunch of exercises that's going to cause you pain. That is a bad recommendation and one that will harm you. You exercise only to the point where you cause a little tugging, a little pressure, not pain. And now, good last question. Are there long-term negative effects of taking hormones for chronic pain? Excellent question. Today, we do not recommend that anybody take hormones unless they've had testing. You've heard the horror stories of the past about how people got cancer, how they got prostatic hypertrophy, or they got adrenal shutdown because they took hormones. But those hormones were given in the days when there was no testing. A lot of women who got cancer of the breast, for example, were given hormones without the benefit of a test. If you start taking hormones and your serum level is normal, expect to get cancer, expect to get a disease. In other words, you're overdosing yourself. You take hormones to raise your level up to normal, not to go above this. You stay in what we call homeostasis. Hormone level can cause you problems if they're too low or they are too high. In other words, you test first, and then you keep the hormone levels within the normal range. I do not know a single case of cancer, prostatic hypertrophy, adrenal shutdown, in which the hormone blood level was kept in normal range. I can't find a single case in which any of these hazards occurred if the physician kept the hormones simply within the normal range. Ladies and gentlemen, I have thoroughly enjoyed this evening. Unfortunately, I'm due out to give a lecture to a group of physicians tonight.
Okay.
I hope to join you again in the future.
Thank you, Doctor. Thank you, Dr.
Anybody
Tennant.
who wants to write to me or send me an email, please do so. I try to answer every one. And I also hope to spend some more time with you in the future.
Thank you, Dr. Tennant.
My pleasure. God love you, and good luck to all of you. Good night.
And I just wanted to thank you, especially everyone is just really appreciative of all the practical and actionable items and information and the hope you've given us.
Okay, and my pleasure. It's my pleasure, and my honor, in fact, to do so.
And we hope to invite you back for another
Please
session if you're able to. Thank you so much.
You betcha.
Good night.
Good night.
And And thank you all for attending this evening. I think we've had a fabulous session. We had, I think, a record number of questions, and I think Dr. Tennant did an excellent job answering those. I want to remind you that our next webinar is going to be on Tuesday, April 21st, Dr. Saad. And also this weekend on April 11th, we're having a physician conference in Cincinnati. If you go to our website on Friday, you will find a link where you can listen to that webinar live. We'll have Dr. Nielsen, Dr. Medikaitis from Cincinnati Children's Hospital, and we'll also have Dr. Ringer from Mayfield Clinic, and he'll be talking about Chiari. So we're looking forward to having you join that session as well. And thank you for your patience, and we will conclude our session this evening.
Thank you, everyone. Have a great night.
Good night.